All right. Hello, everyone. My name is Natalie. Thank you all for being here and for your continued interest in Global Grand Rounds. As a friendly reminder, you are able to get CME credits for being here, and I will paste that link in the chat. Today's presentation is by Dr. Andrius Baskys. Dr. Baskys is a practicing physician, psychiatrist, as well as neuroscientist, inventor, and educator. He completed his psychiatry residency training at the University of Toronto, Canada, Geriatric Psychiatry Fellowship at McMaster University, Research Fellowship in Alzheimer's Disease at the Toronto Western Hospital, and postdoctoral research training at the University of California, San Francisco. During his career, he has taught and conducted research as a faculty member at the University of Toronto, University of California, Irvine, University of California, Riverside, as well as more recently at Western University of Health Sciences. He is also a professor of psychiatry at University of Alberta, Edmonton, and vice president of World Association of Genomic Medicine. Dr. Baskys has published over 200 papers, presentations, and reports on neurodegenerative diseases, mechanisms of synaptic plasticity, and application of stabilized RNA-based technologies in neuroscience research. His most important scientific contributions are in the area of metabotropic glutamate receptor physiology. His current clinical and research focus is on bringing advanced technologies of pharmacogenomics, artificial intelligence, and next-generation sequencing to clinical practice. Dr. Baskys, is there anything you'd like to add before we begin?
Oh, I just would like to thank you for this wonderful introduction, and I would like to thank everyone who managed to log into Zoom and get it working. And congratulations, and I appreciate the opportunity to speak to all of you and share my rather passionate thoughts about genomics, pharmacogenomics, and genomic medicine. And I'm sure many of you had heard about it, and many of you probably know maybe much more than I do. But that's good, and I think we could sort of put our heads together and make sure how we could get this technology implemented. So am I allowed to start?
Yep, go for it.
All right, so let's see. The talk, we're near the railroads here, so that sometimes it's shaking here. That's not an earthquake. So let's see if I could only make sure that this Zoom works. So the talk will be of two parts, part one and part two. And the first part is a little bit about pharmacogenomics, which is application of genetic and genomic techniques in prescribing. And the second part is just a little overview of genomic medicine, application of genomics in diagnosing and maybe treating rare diseases and maybe some kind of other diseases. So with part one, let's see, why do we need to do genetic testing? So I think many people would agree that the drugs overall are toxic. And the individual variability of drug responses is a very big problem. Some people respond to a drug one way, and other people respond in a completely different way. And then unfortunately, or maybe fortunately, adverse drug events are heavily litigated. There is a lot of attorneys who are always willing to take a prescriber to court. And mortality due to adverse drug events is increasing, actually, unlike other conditions. I have this picture here, slightly modified from American Pharmacists Association news. It's not very new, 2016. It captures a period between 2012 and 2016, and it shows mortality for major diseases like stroke, cancer, heart disease. And the columns facing down, they indicate it's a decline in mortality, especially a large decline is in cancer. However, if we look at drug poisonings and accidents related to medications, they keep climbing up. So that's kind of important. And we have to start looking into the causes of it and how to improve our treatment strategies. So one of the currently still widely used and widely popular strategy is blockbuster strategy or one-size-fits-all approach, where one pill is supposed to help everyone. One pill, one injection, one inhalation, something like that. And it has been around for some time, and it usually results in what is called a pharmacological odyssey. And I want to show you how that odyssey unfolds in psychiatry, at least. There is a sort of a fake hypothetical example of a 37-year-old woman diagnosed with depression. So let's say we start treating this lady. And for starters, let's say we prescribe a popular medication, SSRI, citalopram, at a dose of 20 milligrams per day. Unfortunately, these drugs don't work immediately, so we have to give at least 4 weeks to see that there is some kind of minimal improvement, but not enough. So the prescriber doubles the dose and waits another 4 weeks. So after already 2 months of waiting, some mild benefits, mild symptoms are still present, and the doctor decides to discontinue citalopram and try something else, a different class medication. That would be SNRI and venlafaxine, which requires a dose escalation. So we start for 2 weeks, we titrate the dose up, and totally 6 weeks later, on 150 milligrams of venlafaxine, we get some kind of improvement, but unfortunately a lot of side effects. At that point, the prescriber decides to order pharmacogenomic testing, gets results, and prescribes a medication that the person responds with minimal side effects. So total, how much do we have here? 1, 2, 3, 4 months, 4.5 months. So that's what is pharmacological odyssey. And the question is, could we do it differently? Could we start with pharmacogenetics at the beginning rather than waiting for so long? So maybe we wouldn't really need to go to what is here shown in gray. So let's see. If we want to start at the beginning, we kind of want to sort of understand a little bit more about pharmacogenomics or pharmacogenetics. For my Zoom kind of stalled. Let me see if I can get the slide going. Here it is. So with pharmacogenomics, the hope is that we could resort to a different prescribing model, not one size fits all, but a personalized prescribing. And this diagram shows what it would look like. So we would stratify our patients in the different categories. There will be those who respond to the regular dose of a drug, as it's shown here in blue, or some people would respond to a lower dose of that drug, which is fine. And there would be some people who would require a higher dose of the drug. And maybe there would be some people who would require a completely different drug. So this is sort of the dream of personalized medicine. And that dream is not that new. It probably started a while ago. And as a sort of a light joke, I wrote that historically, probably Greeks already knew something about personalized prescribing. But since they didn't write articles in Nature or Science, so that knowledge probably wasn't really preserved. But in 1956, it was noticed that the US soldiers who were stationed in the malaria-infested areas and given Primaquine or a similar drug to prevent malaria, some of these soldiers developed hemolysis. And it turned out that this was because it was a population of people, mostly of African descent, who carried a mutation in G6PD gene. This was later clarified, but the first article appeared in Science in 1956. Excuse me, and that probably would be the beginning of personalized medicine. There were some other things discovered later in 1977. It was identified, the cytochrome P450-2D6 was identified as responsible for increasing duration and intensity of antihypertensive drug, the brisoquine. And then the technology developed further and further. It is quite available now, but in order to better understand, I just highlight few things about the pharmacogenetics. So that takes us to probably a most hated subject in the medical school, which is pharmacology and pharmacokinetics and pharmacodynamics. So what is pharmacokinetics and pharmacodynamics? And pharmacokinetics is the effect of drug dose and to the concentration of that drug in the body of the person. And pharmacodynamic describes the effects of concentration, of a certain concentration onto the pharmacological and to pharmacological action of that drug. The pharmacokinetics depends on a variety of factors. Some of them are listed in this window. That's drug absorption, distribution, metabolism, elimination, and prodrug activation. While pharmacodynamics depends on a target proteins and receptor sensitivity and things like that. Genetic variability can affect both aspects, both pharmacokinetics and pharmacodynamics. In terms of pharmacokinetics, genetic variability affects drug absorption, metabolism, and prodrug activation. And these are the good examples of these inferences. For example, absorption often depends on a gene known as ABCB1, also often referred as glycoprotein P, or MDR, multiple drug resistance protein, which controls drug absorption in some ways. Metabolism of many drugs depends on P450 system, or also known as cytochrome peroxidase CYP enzymes. And prodrug activation also depends to large extent on CYP enzymes. Target proteins, a good example is opiate receptor, OPRM1, which is in some people may have mutations that reduce its sensitivity to ligands such as morphine. These people carrying a mutation would require much more morphine in order to achieve satisfactory pain relief. So going further, the pharmacokinetics allows us to stratify people in roughly 4 metabolizer types. And those could be normal or extensive metabolizers, which would be the people who respond to the drug as expected. So if we give them a medication, so the medication, the drug concentration in plasma would be in a therapeutic dose range. There is another category of people who who carry one in the CYP gene. They carry one functional and one non-functional allele, and they are intermediate metabolizers. So the metabolism of the drug is somewhat impacted, but that impact is not that great. Most of these people, most of these individuals respond to the drug just fine, and they do not show any kind of signs that this drug is not metabolized properly, except when the phenomenon of phenoconversion occurs. And I'll just get back to the phenoconversion, but I want to first mention a poor metabolizer phenotype. These are individuals who carry 2 non-functional alleles in one of the CYP enzymes, in an enzyme that is responsible for metabolism of a particular drug. It's a good drug I could mention here as an example is antidepressant duloxetine. Many of you may know and it is metabolized by the CYP enzyme 2D6, almost 100%. So if a person carries two non-functional alleles in that 2D6, that person would not be able to metabolize duloxetine and would have a lot of side effects, of course. Now, if a person is intermediate metabolizer, that person carries one defective allele and is metabolizing the drug, that person might be prescribed by a different medication by another physician, another provider that would inhibit the enzyme that is already compromised partially. That phenomenon is called phenoconversion because it would make that individual appear as if he or she is a poor metabolizer. So in clinical practice, that would appear that the patient who never had any side effects to a drug that is being prescribed suddenly develops side effects to that drug. And that occurs because somebody else gave that patient another drug that inhibits that partially compromised enzyme. And then there is a category of individuals called ultra-rapid metabolizers. Those are the ones who have whose drug metabolizing enzymes work in overtime, in overdrive, and they metabolize the drug so fast that the drug has no chances of acting, and they usually listed as non-responders. So here I have some examples of what the genetic reports look like. So in order to navigate this maze of potential phenotypes, normal, intermediate, poor, ultra-rapid, the best thing to do is to order a pharmacogenetic test, which is, at least here in the US, it's rather simple. It's a simple procedure. It's a saliva test. Many laboratories do that, and the results are listed. I showed the one example here in this report. The tests are not very expensive. Most insurances pay for it, there's one test for a lifetime, so it does not have to be ordered multiple times a year because it's a genetic test, a DNA test, so DNA remains the same throughout the life. So let's take a look what these reports look like. This is an example of one. And this is a report of a patient who does not really have any kind of unusual phenotypes, doesn't exhibit any unusual phenotypes. And here in the report, on the left, we see listed the main CYP enzymes that are involved in drug metabolism: 2B6, 2C19, 2C9, 2D6, 3A4, and 3A5. Here we see the genotype, and usually the genotype is in these reports are expressed as star alleles, and number one means that it's a normal genotype. There is no mutations here. So the genes come in twos, so we have 1 and 1, so 2B6. And so this individual is a normal metabolizer on all of these genes. So that individual can be prescribed basically any drug that is known to be metabolized by CYP enzymes, and we would not expect any unusual reactions. 3A5, it's a little bit an outlier, and 3A5 is not present in Europeans, which shows here 3-3. That means that this gene is absent. So it's called a European non-expressor. It doesn't play a very big role. It metabolizes drugs like midazolam or alprazolam, and usually 3A4 takes over and helps out. So now let's look at another patient. So this is another patient, and that patient, everything looks pretty much the same except for 2D6. As you can see, 2D6 shows here 1 and 4. 4 means that that gene is disabled by mutations that are present in it. So that means that roughly that person is metabolizing a drug that requires 2D6 only in 50% capacity. So duloxetine, again, it's a good example. Tramadol requires activation by 2D6. Again, it's going to be impacted. So everything else is the same. So for that patient, maybe duloxetine could possibly cause more side effects than expected. So maybe another drug, another antidepressant could be prescribed instead. Now let's look at another patient. Oh, this is a very complicated situation. We have, first, let's take a look at 2D6. 2D6, the patient has 4 and 5. 5 means a deletion, 4 means that it does not work. So that means that person does not have CYP2D6 at all. So if we give that person a drug like duloxetine, its metabolism will be severely impacted. And at a regular dose, that person will likely have significant side effects from duloxetine, as well as from fluoxetine, Prozac. 2C19 is responsible for the metabolism of some SSRIs like citalopram and escitalopram. And in this case, 17 means that this gene has gain of function mutations, which means that it works too hard. And that means that the medications like citalopram and escitalopram will not work because they will be metabolized very fast. Another medication that is affected by 2C19 mutations is Plavix or clopidogrel, which requires activation by 2C19. And in this case, clopidogrel will be overactivated. So that means that the person who is receiving that medication may develop bleeds. 2B6 metabolizes one psychotropic drug, which is bupropion, and also metabolizes general anesthetic propofol. And in this case, we can see that this person is an intermediate metabolizer, meaning that 2B6 working in about 50% capacity, so that if we prescribe bupropion to that person, there is a good chance that that person has more side effects to bupropion, which is anxiety and insomnia, not very desirable side effects. And in terms of propofol, and I know how that works because I am intermediate metabolizer for 2B6. And I know that after I had one small surgery where they used propofol, they couldn't wake me up at the end of it. Hey, wake up, they're closing the hospital. And I still wanted to sleep. So the drug effect lasts much longer for the intermediate metabolizers. So these are just examples of several CYP enzymes. 2D6 is a very important one. And I want to talk a little bit more about 2D6 enzyme. 2D6 has about 130 genetic variants. So that's how much variability and diversity is among individuals. It is responsible for metabolism of about 25% of all prescribed drugs. And that includes antidepressants like duloxetine, doxepin, fluvoxamine, fluoxetine, venlafaxine, some antipsychotics, aripiprazole, chlorpromazine, olanzapine, risperidone, and is responsible for metabolism of some opiates and activation of some prodrugs, such as, for example, codeine and tramadol. These drugs do not provide pain relief by themselves. They need to be activated by 2D6. And I'll have some diagrams here to show how that works. It's very important because without proper activation, and both tramadol and codeine are frequently prescribed. Tramadol is commonly prescribed in family practice clinics as a pain reliever, and codeine is often prescribed by a dentist. So by themselves, these drugs are not really good pain relievers. They need to be activated. And once they activated by CYP2D6, as this diagram shows, they release the codeine releases morphine, which binds to the opiate receptor. Tramadol is not morphine, it's a synthetic morphine analog, but it also binds to the opiate receptor mu1. So that's what happens with in an individual who is normal or extensive, as we call it, metabolizer. So it has a 2D6 gene and the resulting enzyme not particularly affected by the mutations that they exist. Now, if we have a poor metabolizer, this activation does not occur. And if a person is given codeine, the released morphine will activate opiate receptors only mildly, and there will be no or little pain relief. Now, if we have an individual who has ultra rapid metabolizer because of, for example, CYP2D6 gene duplication, that person will get the codeine activated extensively and maybe too much, and a lot of morphine will be released, and the morphine toxicity may ensue at the regular doses of the drugs like codeine or tramadol. So, CYP2D6, it is an important, and it's interesting, the mutations that occur, and I mentioned about 130 variants that exist in CYP2D6 gene. They are differentially distributed around the world. And since this is a worldwide presentation, I included this slide to show how it affects, how these mutations appear to be distributed in different geographic areas. This is the normal extensive metabolizer, and this is the distribution in Europe, in American Southwest, in Eastern China, and in North Africa, Saudi Arabia region. However, if you look at this diagram, the intermediate phenotype, that has completely different distribution, and most of intermediates live in Eastern Asia, in China, and even in South Asia. Poor metabolizers are often found in American Southwest and among Europeans, but it's not that pronounced. I think it's up somewhere 5 to 7%. What is interesting is here that in North Africa, Mediterranean region, Saudi Arabia, and adjacent countries, we have a lot of ultra-rapid metabolizers because of a large proportion of gene duplications and even triplications that are found in this geographic area. So it is important to keep in mind that if you have a patient coming from North Africa, the Mediterranean region, there's a good chance that that person, it's a 30% chance that that person might be ultra-rapid metabolizer. Even without any genetic testing, one could make this sort of guess and avoid prescribing medications that are metabolized by 2D6, or at least expect that these medications may be ineffective. So in our clinic here in the inland empire of Southern California, how many mutants do we have coming in? And the reality is there's a lot of mutants among us. No one is innocent. We all carry mutations of different kinds. On average, it's 2.2 variants per subject who appears, at least in my outpatient clinic. That 29% of patients will carry at least one mutant allele. Well, mutant is probably not exactly correct word. Let's say variant allele. That would be more correct, because the word mutant usually is reserved for situations where we know that a parent did not have a variant, but the offspring has a variant. So we say that a mutation occurred. So in this case, we know nothing about parents, so let's call them variants. And about 11% who carry 4 variant alleles, and so it's not a small proportion. The genes that tend to mutate mostly, again, is 2D6. genes that tend to mutate least is 3A4. 3A4 metabolizes several antipsychotics and some antidepressants. So if we do not know anything about genetics, so prescribing, and we want to prescribe antidepressant, it's if we prescribe something that is metabolized by 3A4, it will be pretty safe that we will not encounter a situation where the person cannot metabolize that particular drug. Again, as I mentioned, some mutations are loss of function and some mutations are gain of function. The most are loss of function. Most mutations or variants that occur, about 80% are loss of function, but it's about 20% are gain of function. And I already mentioned a couple of them. I mentioned 2D6 ultra-rapid metabolizers, predominantly they are found in a geographic region of North Africa and Mediterranean, and also the people who have 2C19 variants. So we did a study in our clinic just to see if actually this information about the person carrying a variant of one type or another changes anything in terms of prescribing. And to do the study, we needed a good outcome measures. You know, we need always an outcome measure. So we came up with an outcome measure that we call the badness score. So what's a badness score? Well, we showed the badness score decreased. So the badness score is, for a given patient, we called a number of medications that interact with variant genes. So let's say the patient is on 3 medications and they all interact with variant 2D6. And so the badness score will be very high. But we can have another patient, even a patient who carries mutation, and that patient may be only on 1 or maybe 0 medications that is or are metabolized by a variant, by the enzyme dependent on variant gene. So what we found that in our clinic, if a prescriber receives genetic testing results, the badness score tends to decline significantly. And here we just, on average, these are the numbers. I don't really mean that much, but this is a maximum number of drug-gene interactions. So the physicians, prescribers tend to prescribe fewer medications that are more likely to interact or depend, whose metabolism depends on the CYP enzymes produced by mutated or by variant genes. It's a very, very long sentence. I hope everyone will remember it. Okay, so in conclusion of part 1, is my impression that overall pharmacogenetics, and we often refer to that as PGX, works. Patients love it. They feel that they get a better quality care if the genetic test is ordered and the medications are prescribed that way, because the likelihood of adverse drug reactions is somewhat decreased. And so the patients are happy. It saves money to some extent because the pharmacological odyssey is shorter. And this is not only my conclusion. There's been many studies done. The technology is not new. So it's been many studies done in large leading research institutions, large hospitals, and they all concluded that yes, it does save money. It shortens the pharmacological odyssey. And it kind of assures that medications are prescribed more rationally rather than just simply guessing what are we going to give the patient today. There are downsides too, unfortunately, like everything has its own downside. The one big downside is that pharmacogenetics adds a layer of complexity. So we now have to think not only of drug-drug interactions, as many recall that the people don't really like it that much. So it's not only drug-drug interactions, but also drug gene interactions. So this is kind of very complicated now. And it takes extra time to explain these results to the patients. And the patients sometimes they don't quite understand that. These are complicated things if we start looking in the detail. And for example, I had a patient and I explained to him that I did the genetic test, and then one of his enzymes has a variant and he does not metabolize certain drugs very well. Therefore, I would prescribe something else. And the patient immediately asked him, "Doc, is that because I've been drinking?" And of course it's not, but I had to address that issue of patients' perceived guilt, that maybe he did something wrong in his life, and now his enzymes, the CYP enzymes, are not quite as they would be expected to be. So one has to be prepared to deal with these kind of issues. So that's how much about pharmacogenetics, and I'm going to switch without a break to part 2, and then we may have a little bit of time and have maybe answer some questions. So part 2 is genomic medicine, and that's also genetic testing, but it's a little bit different. And while in pharmacogenetics, the testing was focused on a particular set of genes and on particular locations in these genes. That's where we test was looking for variants. In genomic medicine, the testing includes the entire genome. We look at the entire DNA, and we do not limit ourselves to any particular gene or location. So how good is this genomic medicine? So, and what it is. So it does offer some sort of diagnosis and treatment that could be guided by genetic data. That diagnosis and treatment requires the knowledge of human genomes. That means that it's necessary to know what a particular gene, what kind of disease a particular gene is associated with, or what kind of condition or trait a particular variant could be associated with. That information is obtained through 2 kind of major sources. One is the next generation sequencing of a patient's DNA, and I'll show you a little bit what it looks like. And also it depends on bioinformatics analysis, which is very computer intensive process requiring searches of multiple databases and data processing. So I'll just show you in a moment of next generation sequencing, but here I just wanted to focus on the applications of genomic medicine that is at this point is probably most commonly used, and that is undiagnosed and rare diseases. And a rare disease, by definition, is a disease or condition that affects less than 200,000 people in the world. Now, there are many people living with rare disease. The slogan of rare disease is, "We are rare, but we are many." There are about 7,000 of rare diseases. So overall, in the world, the estimate is that there's about 350 million people living with rare disease. That's a lot. In the US, this website that I have here listed on the top of my screen estimates that there's approximately 25 to 30 million Americans who have a rare disease. And it takes about, on average, 7.6 years to make a correct diagnosis. And many of them remain undiagnosed. Now, when genomic medicine can help with that, and it does, and it's been shown that in about 20 to 40% of cases, the rare disease diagnosis is more likely to be made correctly than using standard clinical practice methods. Here I have an example of one rare disease, and that is known as Kleefstra syndrome. It's characterized by variable level of mental retardation, psychomotor development, seizures, behavioral abnormalities, facial dysmorphism, urogenital defects, and it depends on one gene, on histone methyltransferase 1, EHMT1, in most cases. And I have faces here, they're taken from internet, one you can see that many of these individuals have the unibrow, and that's sort of one of the facial characteristics of Kleefstra syndrome. So not everyone who has unibrow has a Kleefstra syndrome, but those who have Kleefstra syndrome are more likely to have a unibrow. So this is a patient that we saw in our clinic, a 27-year-old man. He was aggressive from age 15, nonverbal, responds to commands, but follows commands, but doesn't say anything verbally, lots of stereotypical movements. Medically, he had inguinal hernia removed, and he had a missing kidney, actually. I mentioned that's one of the signs of Kleefstra syndrome, urogenital effect, and he had a unibrow. So we sequenced his DNA using next generation sequencing. That was one of our first patients. And we found a likely pathogenic variant in the gene EHMT1 known to be associated with Kleefstra syndrome. So there's a good chance that this gentleman did have Kleefstra syndrome. So since I promised to tell you what next generation sequencing is, I have this short video here taken in Hudson Alpha. This is a sequencing machine. There's lots of them. They look a little bit like a dishwashers, and that's where they are loaded this patient's DNA and they sequence it. So how do they sequence it? So and then next generation sequencing is different than what it used to be, classical or Sanger sequencing, where DNA was read letter by letter. That was a slow and expensive process. Now we have a cheap and inexpensive and fast process, but not very accurate, but it's okay. So this shows the results, the outcome of next generation sequencing, and I'll explain what this means. The DNA is broken into small pieces called reads. And here you can see these little like bricks, these are the reads. And then the computer tries to reassemble what the DNA would look like if these reads were accurate. So that's very computationally, very intense process, but we get this sort of blurry kind of thing, which shows that's the coding area. And we can see the actual gene is right here. So you can see the coding areas right here, but that's what it looks in the next generation sequencing after the computer reassembled the gene from these little pieces. And as you can see, there is this green little thing, which is a letter change. So this was calculated to represent a variant. And that's the variant that we're looking for. And we are hoping as a holy grail that to find the variants that will explain diseases and maybe hopefully will help us to treat them. So let me tell you a little bit more about the variants. So often variants are referred as SNPs. And the SNP, or single nucleotide polymorphism, is the area in the DNA where the letter tends to change. So in one person, it could be A, in another person, it could be G, and in the third person, it could be T. There are 4 letters. So it could be a change. And that change could be significant or not significant. And there are about 10 million these SNPs in a normal human DNA. And one gene has roughly from 2,000 to 3,000 SNPs. And I'll show you what it looks like. So once we sequence it, we sort of see disease as a database, really. And we use bioinformatics analysis to arrive to the diagnosis. So let me show you what a gene looks with the SNPs here. So here we have a gene known apolipoprotein E gene. And many of you had heard that gene. It's a very well-studied gene. It's very important in cholesterol transfer through the membranes. And it is associated with a number of diseases. One of them is Alzheimer's disease. And the individuals who have certain variants in ApoE gene tend to have a higher probability of developing Alzheimer's disease earlier in life. So here is a gene. It's from here to here. These gray blocks means the coding area. So this means also known as exons. So they code for the protein. And these other areas, these are empty ones, they're called introns. They don't carry a coding sequence. Now, I want to show you here, in this block right below here, these are the SNPs that occur in ApoE gene. And as you can see, all 2,750 SNPs are here. The different levels in the graph indicate different probability of finding a SNP in a population. So some SNPs are very common, everyone has it, and some SNPs are very rare. No one has them, or just very few people here. Here we see the clinical significance of the SNPs. And the red lollipops means that these are pathogenic or deleterious SNPs, likely associated with a disease. So if we find a person carrying a deleterious SNP, we can speculate that that is the cause, or at least a contributor to a particular disease. So the next generation sequencing is primarily interested in identifying these deleterious pathogenic SNPs and trying to see if something can be done about it. And I'll show you what can be done about it. This is a case example. We call it our poster boy. It's a young gentleman. He was 25 when he came to the clinic, and he already had seen most of the doctors that there exist in Southern California. He came to my clinic with his mother, and the mother was carrying a suitcase. That suitcase had reports by different specialists, laboratory tests, analysis, conclusions, and so on. And nobody could figure out what the problem was that he had. And they concluded that it's all in your head, man. Go see shrink Dr. Baskys, and he will figure it out. So he came to us complaining of intractable migraine. And actually, he had a bad migraine with aura. He had severe photophobia, vomiting, ataxia, mental confusion. And during the attack, he could not speak. He could not walk. And actually, his life was very difficult. His symptoms started when he was little, 3 or 5. And one can imagine easily how that affected his life, because he had these frequent bouts of vomiting. So he could not participate in any kind of real social life as normal 25, 26-year-old would participate, because his social activities would get interrupted with this vomiting, confusion, photophobia, and nobody could figure out what it was, and even less how to treat him. There was no neurological disorders in the family history. There was no working diagnosis. He was treated with zonisamide, rizatriptan, fluoxetine, ondansetron, quetiapine, Botox injection. Nothing really helped. So we sequenced his DNA, and we found in a gene called CACNA1A, which is calcium channel, predominantly expressed in cerebellum. It's also known as PQ, calcium channel. This is a gene, and at this end of a gene, we found these 2 mutations. They're kind of barely visible right here, but when we put them in a diagram, this is a diagram. This is not a real finding. It's just a diagram of that gene, the protein. It's a calcium channel protein. So the mutations occurred in this area, and it turns out that somebody already reported mutations occurring in that area, and these mutations were already known to be associated with episodic ataxia type 2. So that was his diagnosis, actually. It could several other diagnoses, migraine, familial hemiplegic type 1, and so on. But the good news for that gentleman was that this was known as a treatable condition. And what the treatment was, it was a diuretic, acetazolamide, that turned out to work just fine. And he was treated with 250 milligrams of acetazolamide 3 times a day. We didn't treat it, I'm a psychiatrist, but he was treated by a neurologist. And there was a significant and lasting improvement and affected very many parts of his symptoms, particularly the vomiting, to the point that his quality of life improved significantly because he was able to do what most 25 or 26-year-old people like to do, like go to school and socially interact and so on. So, just in conclusion, there's a couple of points to consider. The link between the genomic findings and the disease is not simple. It's not straightforward. And interpretation of genomic information and explanation to clinicians and to patients may be difficult. The sequencing technologies have inherent shortcomings, and the data analysis is not straightforward. We still don't know very many things, but overall, it's promising technology. It requires knowledge of some bioinformatics tools, which is not that insurmountable. The sequencing can be done. There's a lot of laboratories today. It's not that expensive. I think it's $200 to $300 for the next generation sequencing. So this done once in a lifetime. I think it's not that bad. I think one can hope that this presentation will encourage those who are interested, healthcare practitioners, to see if DNA sequencing technologies can be implemented in your practice. So thank you so much for being so patient, and I'll be happy to answer questions. There is a couple of email addresses. If anyone wants to contact me for any additional clarification or anything, please feel free, shoot me an email, and we can see if I can help you in any way. Thank you.
Perfect. Yes, I'll also be putting my email, the link to our YouTube, the form for CME credit, and our Facebook in the chat, but it looks like we have a hand raised, so you can go ahead.
Yeah, thank you very much for the very interesting topic. Now, there's always this concept of a double hit, where you have some genetic mutation interfering with some environmental factors to, unmask the mutant gene. Is that still what applies? That's one. Then secondly, there are some genetic mutations that are associated with certain disease conditions. I want to use Alzheimer's disease, for example, where you have the apolipoprotein E4, and then for the presenile dementia, where you have the amyloid precursor protein and presenilin 1 and 2. Now, in patients where you find out that patients have mutations in these genes, how does it translate to managing the patients better? Does it help the patient? Knowing that these mutations are there, does it reflect in management of the patient, as well as the relatives of the patient? You have a patient that has Alzheimer's disease, for example, and then you find out that these mutations are there. How does this help the patient? Thank you.
Well, thanks so much. It's a great question. It actually reminds me of one of my supervisors when I still was a postdoc. who listened to the question and said, it's a great question. What was the question again? So,
Yes,
let's see the first
can you hear
part.
me?
So, yeah. The first part was, I can give an example. For example, these G6PD mutations. I know the people didn't know much about it, and once we learn about this G6PD glucose mutations, and the people just need to avoid hydroxychloroquine. That's sort of one sort of way to deal with that. The second question is kind of complicated. What we see is usually the one mutation is not enough to have clinical phenomenon. And yes, true, there are some mutations that are likely to be associated with diseases, and we all know about BRCA mutations, but usually there is more than one mutation. And in this, for example, in this, I think we see oftentimes in this case that I showed the case here, there were some other mutations associated with that gene. I think it had like at least 2 mutations, and in that CACNA1A gene, but there probably were some more. So we see more mutations in people presenting with clinical symptoms, and I think we can probably, I think the current state of the art is that we kind of could be successful in finding the disease, and maybe we're finding a mutation that explains the disease in about 40 to 50% of cases. I don't know, did I answer your question, or still something left there?
Yeah, the only one that is left is, you make a diagnosis of a genetic mutation in Alzheimer's. Does it help in managing the patient? Does it help, or it's just for academic purpose to just know that the patient has some genetic mutations that can predispose to Alzheimer's, and it doesn't reflect in the management of the patient?
Yeah, I do not know. I do not know how would that affect management of Alzheimer's in this case, but in other cases it may. I have a case, a patient, which because of a short time, I could not present, but I have a patient with severe depression since she's now 69, and that's since age about 8. She's been depressed. The mutation is one of the NMDA receptor, one of the glutamate receptor genes, I think GRIC3, which is a receptor to kinase. And the mutation is pretty deleterious. And what we learned looking at her, and she's been treated by a variety of doctors and with a variety of drugs, and her depression is always there. So it turns out that there are databases you can try to select medications that would allow to upregulate the gene that is underexpressed, or downregulate the gene that is it's working in overdrive. And in that case, we found that the valproic acid could potentially upregulate that defective GRIC3 gene. Was it? I think it was GRIC. Yeah. So what we did, and no one has ever done that before, we started treating her as if she was bipolar by prescribing her Depakote. And actually, it's been already 2 months, and she says she's feeling better. So I don't know, maybe that's a placebo effect, but she does say that she's feeling better. So it is, but I do not know if there is any kind of ways to address the issue of the presenilin that you mentioned, or A4E variants. There might be some kind of ways. I've been looking into that, but I do not know if there is any good science helping people with some kind of actions what could be undertaken at this point. But the field is moving forward pretty rapidly. So the patients who have some mutations that are not amenable to treatments today may be amenable to treatments a year or 2 years later.
Thank you. Thank you.
All right. Anything else? Okay.
Any further questions at this time?
Thanks so much for actually coming up with this question. You know, if you would like to, the Dr. Sydney, yeah, if you would like to continue the discussion, just shoot me an email and we will connect, you know, and see how we can sort of address that maybe in more depth.
Sounds great. Well, thank you, Dr. Baskys, for your presentation. Thank you, everyone, for your continued support of Global Grand Rounds. Our next Global Grand Rounds will be on October 12th. So you can go ahead and mark that date in your calendar. And again, in the chat, I have the links to our YouTube where I'll post this recording, our Facebook with updates on all of our events, and my email, as well as the CME forms for credit. And with that, we'll stop the recording.
Okay, well.